Okay. Hi. Good to see everybody. So I'm nealcoehn, and this is our second in the public mental health welcome series. And our guest tonight is Dr. Adam Perpati. And Adam is the Executive Deputy Commissioner at the DOHMH, and he oversees the Mental Hygiene Division. And for those of you who may not be aware, the Health Department and the Department of Mental Health, Mental Retardation, Alcoholism Services merged in January or February 2002 into one agency, which is now the DOHMH, Department of Health and Mental Hygiene. And the vision behind that was that the city would be better served by a more integrated public health model. And historically, mental health and mental hygiene related services, including substance abuse, of course, and developmental disabilities had been very marginalized and quite separate, and the agencies had very different modes of operating. When I was commissioner, as a psychiatrist, I was appointed commissioner of the Department of Mental Health initially, and I became very jealous of the Department of Health's ability to recruit recently trained public health folks with MPHs who were bright-eyed and bushy-tailed and ready to go. And in my agency, the Department of Mental Health, we had a lot of social workers who were great, but who were often coming to us because they were clinically a bit somewhat burnt out by the rigors of working in New York City, and generally were not trained in a population-based model. So we thought that the integrated model would be a win-win for both agencies. And I think over the course of the last decade, there have been some important steps that have been taken, and since Adam took over the reins of the Mental Hygiene Division as a medical epidemiologist who trained at the CDC and at Harvard School of Public Health, and although not trained as a psychiatrist, he's been an early adapter and has, I think, made a lot of progress in bringing the Mental Hygiene Division toward a population-based perspective. And he's going to talk to us today on public health approaches to improving population mental health in New York City experience. And in the course of this, he's going to give us some insights into the research agenda that the Mental Hygiene Division is looking to accomplish. And we can think about how we, as a relatively new kid on the block, might be able to contribute to that vision and to that agenda. And for Patrick.
Thanks. Thanks for having me. It's great to be here. It's not the first time, and it feels very comfortable. Of course, I have a lot of friends and colleagues in the audience, and so hopefully we can make this kind of informal, and we can have a conversation. Thanks to Neil for inviting me. Of course, the credit for bringing the two agencies together rests largely with him. That vision of an integrated agency where health and mental health are more closely linked, and public health approaches are brought to bear on challenges of public mental health. It's really sort of a result of a lot of Neil's vision, and a lot of what I'll be saying today, tried to think about in the context of the book that Neil edited with Sandra Galea at Columbia, and so some of this is, I think, trying to articulate some new approaches and new directions for the health department as we think about this challenge. I'll speak a little bit about some of the work we're doing presently, and along the way, so it'll be a bit of a mix of sort of future thinking and current work, and along the way, as Neil said, to try to think about what the research gaps are, where academic government partnerships might be fruitful, and things like that. So please feel free to interrupt me as well. And just, sorry, I didn't ask you ahead of time, the time check. But I'll speak for about 45 minutes.
Great.
So, so I'm a government public health guy. So I'll speak about things somewhat in the context of our work here. These are, this is the national standards for what I found it a useful framework to try to think about how to integrate challenges of behavioral health into our work. Because not all of these really necessarily fit so closely with the work of the public mental health system. But I'll try to go through and give some examples of them, of what sorts of things we're doing in the context of these so-called essential public health services. And this larger challenge of how to think about prevention when it comes to mental illness. When it comes to substance use, I think it fits the public health framework a little more easily, but mental health, I think there's some challenges in thinking about prevention, but some very exciting evolution and research that offers us some strategies, how to think about health, mental health at a population level, and increasingly how to think about some of these environmental or contextual influences on health that are well described for other conditions and beginning to be described increasingly for mental illness as well. So that this notion of prevention and serious mental illness, I'll talk later about sort of the idea of what the prevention agenda is for schizophrenia, for example. But I just wanted to sort of illustrate a bit of the tension between the traditional work of a public mental health agency and sort of thinking about it from a public health perspective and a prevention perspective. This is the SAMHSA definition of recovery, and sort of promoting recovery and a more effective and stronger system of mental health services for people with serious mental illness is a priority and is a sort of orienting feature of our work. But the recovery perspective is very much one. It's not really a prevention perspective. It's explicitly not a prevention perspective, actually. And so, when most of our historically, most of our efforts have been invested in this work, which is critical, how do we think about combining a prevention perspective as well? So, I don't need to talk too much about Jeffrey Rose to this audience, but just to say that, when Jeffrey Rose was sort of trying to articulate principles of prevention at the population level, he made this important observation that the mean rate of certain risk factors or exposures in a population predicts the rate of extreme outliers, which was a very interesting and not necessarily intuitive finding. An interesting version of this is alcohol consumption. This is data from the multiple countries. So it's national data compiled across countries, and they're tracking the mean level, for example, here, mean level of consumption with the prevalence of the extreme, of heavy drinking, of alcoholism. So very interesting at the national level that the average level predicts the mean, predicts the extreme. Which the conclusion being that if you want to do something about outliers, you need to think about the extremes of the population in the context of the entire population. And that strategies that might influence the mean might also influence the extremes. And so the question is are there analogs for mental illness, for example, for depression, for child mental health, where how we are doing at the population level will tell us something about the rates of illness across the population. And conversely, can we think about prevention by targeting the mean or the median rates of these exposures? So I'm not saying that there's great evidence that that's true, but I think a challenge when we think about prevention for mental illness is whether these types of phenomena actually exist. So these are the sort of classic Jeffrey Rose arguments that when exposure is distributed across the population in a, say, normal distribution like this, and risk increases in this manner, then you can actually achieve great reductions even in the extremes of illness in a population by shifting the entire curve to the left. So what might that look like when it comes to the mental health of the population? What can we be doing at a larger societal level to think about the overall mental health of the population that might actually have benefits in reducing the rates of sort of diagnosable mental illness? Okay. So the first the first topic there in the essential public health functions is the surveillance. And so this is surveillance. It's a core function of the health department. And I would say that traditionally for mental illness, we don't have great surveillance structures. We don't have great surveillance systems. We've been trying to do better over the last several years about gathering more information on the prevalence and distribution of mental illness in the population. And I wouldn't say we're sort of there yet. I would say this is sort of one of those sort of gaps in our knowledge, in our processes. So, and part of the reason I think why that exists is that mental illness, in contrast to some other conditions and exposures that we care about in public health, so you can think about sort of what we do surveillance for. We do surveillance for risk factors for illness, behaviors, for example, like the community health survey that we do with the health department, 10,000 people that we call up every year and ask how they're doing. We can ask a lot about behavior, smoking and drinking and sex and all kinds of other things. But mental illness, of course, is not a behavior. It's harder to ask about it in that way. We ask about diagnosed conditions. Have you ever been diagnosed with this? Have you ever been diagnosed with that? Which can be useful for mental illness, but most people with mental illness are actually not diagnosed. And so we're left with, traditionally in national studies, left with techniques like administering scales to individuals for depression or anxiety or whatever, which are logistically and sort of in terms of the space and the availability of time and survey, hard to do. So there's a number of challenges in collecting information about mental illness in the population. The other challenge is when doing surveillance for mental illness, you want to think about severity and how it's distributed in the population. It, again, offers a level of complexity that we may not have for other conditions. Of course, there's no lab tests either. That's another, when you think about HIV surveillance, for example, we do surveillance in many ways on laboratory results. No such analog mental illness. So what do we have? So this just runs through some of the examples. So this is the National Behavioral Risk Factor Surveillance System, and it's asking about depression. And it asks about depression by using the PHQ scale, right, the 9-item scale, and we can generate distributions across the country. And we do that same thing in New York and in the city as well. The large national surveys over the years, these are some of the ones you're familiar with, our National Comorbidity Study, the most recent ones. This is the study that produces that 1 in 5 or 1 in 4 people are diagnosed with mental illness in the past year. But this is an in-person interview using scales, a long in-person interview using scales. So logistically difficult to do. But in those surveys, we get not only the prevalence of different conditions like this, but something about utilization of mental health services. So this is sort of this often cited number that only 40% of people with DSM diagnosis are at priority care. So in 2004, so with that backdrop of the difficulties in doing mental illness surveillance, the department embarked on an ambitious, this was actually under Lauren's leadership, 2004, an ambitious effort to do an in-person interview survey for for a variety of conditions, including mental illness, and used some scales for depression and anxiety. And it allowed us for the first time at the local level to describe the prevalence of different conditions and look at different populations. So this is just, I pulled out the anxiety data. And we were able to look at treatment. And of course, the treatment rates for diagnosed people were extremely low. This isn't surprising. This is consistent with what we know nationally. So we do this kind of surveillance currently using, we have limited amounts of data that we collect in our community health survey, our telephone survey of New Yorkers every year. And then we have, back in 2004, we had an in-person survey. And that's, we don't have many other population level data sources. Here are some of the things we're doing now to improve that and get a better picture of the population at large here in the city and their profile around mental health. We've expanded, and this is sort of in progress, and hopefully over the next several months you'll start to see some more data coming out of the health department on this. A mental health module to the survey, so actually dedicating some space in our large survey to a specific set of questions around mental illness. Actually following up people in that telephone survey who score high on the Kessler's 6-item scale of psychological distress, to then go back and interview them in greater detail about their condition. Looking at new opportunities for using new data sets for surveillance, in particular Medicaid. So Medicaid Medicaid claims have been used for health services research. We were interested in sort of taking a look at that from a population perspective. Can we use the Medicaid files to do surveillance and other data sets? In addition, and this again is sort of remarking on sort of what the data gaps are in the city, we don't have great information on what, not only the basic surveillance measures, the prevalence across different populations and things like that, but needs assessment. Need for services, need for medical services, for social services, at the population level, we just don't have. So hopefully in the next literally several weeks, we'll be embarking on a large survey of hospitalized patients, trying to get a picture of the most serious end of the mental illness spectrum, and ask about a variety of medical and social needs. So that's also fairly unprecedented. And then importantly, working with you folks here, Lauren and her group, to continue and do a follow-up to that 2004 City Health and Nutrition Examination Survey and do it again. And not only are we going to do it again, but we're going to try to use this opportunity to get some validity and some comparison between these various scales that are used. Different groups use different metrics, and that also is part of the confusing picture of mental illness surveillance. And we think that some of the aspects of what we're going to do in the survey here will actually add significantly to our knowledge about which scales work better with the others, what does one measure and the other one measure, in addition to giving us general surveillance and data. Do you want to say anything more about it?
No, it's a challenge. The mental health component is a real challenge. We've gone back and forth almost more than any other section, but it's one of the most important ones. So we're very supportive and excited about it, but it's difficult to do.
It's difficult. It takes up a lot of space. And,
what age group are you?
Adults 20 and older.
So I would say that in general, in terms of gaps, like I said before, our ability to describe the population in the city with mental illness and understand sort of both the interaction with the medical system and the social service system and needs is relatively poor, and that's I feel like the public mental health system and the system of care for people with HIV have a lot of analogs. I think we have a lot more information on the population of our city with HIV. Another group with a lot of social service needs, a lot of interactions with public systems, and I think there's some examples from that sector, this in terms of surveillance anyway, that we could be drawing from. Okay, a few other sort of things to say about epidemiologic strategies. We've been interested in trying to articulate in the city where mental illness sits and how important it is in terms of prioritization for programs and funding. This is a challenge because the easiest thing for us to do in public health is to measure, not the easiest, the most basic thing we do in public health is to measure births and deaths. Again, this is something that Lauren led in our department for many years. And mortality is one of the key ways that in public health we prioritize what to invest our efforts and our money in. but mental illness, of course, doesn't fit the mortality paradigm. And so, you know, we're interested in always in looking for ways of prioritizing different disease states using measures not only of mortality but of morbidity. And familiar with these different ways of doing it, the qualities, the different techniques for doing it. But the DALI technique is basically a way of combining mortality metrics, years of life lost, with some measure of disability, which is a complex formula that has to do with the number of cases, the prevalence of the condition, the level of severity, and then this sort of a bit fuzzy notion of a disability weight, the relative weight of a year spent with that condition compared to a year of perfect health. And when you do this, and you combine disability years with years of life lost. This was done in the global burden of disease studies from many years ago. This exercise is one of the things that sort of, when you look at mortality, this is global, this is, you know, international data. You see the traditional heart disease, etc. This is where, you know, depression sort of sprang into the top three and was quite effective at sort of highlighting the role of mental illness and its importance in the larger public health framework. So this is internationally. We tried to replicate this data and see it's, you know, it's old. We don't have the ability to fully measure, for example, the prevalence of these different conditions in the city, as I said before. But using, essentially extrapolating from national data, we were able to show, for example, that depression, you know, the blue lines is the contribution from mortality, and the red is the contribution from disability. So you see here, cardiovascular disease continues to be the leading cause of DALIs in our city, but depression is number 2, alcohol is number 4. And they're red, right? Because these are not killers per se, the way these other conditions are.
But you separate things like alcohol use and depression, and probably substance use and suicide. I don't know where they fit in, but like, so.
I mean, you could add them, and right. Like, for example, this we took apart different cancers, and sometimes we lump those together.
Because there probably is a mortality component to it, right?
Right. If you put in suicide, for example, which is in here somewhere lower down on the list. Yes, you could imagine it as well. So this is prioritization. You know, we've also, you know, for example, in our work around, this is moving a little to substance use, but for alcohol, trying to estimate the contribution of alcohol consumption to overall mortality using these population attributable risk calculations that combine the prevalence of the behavior with the risk of that behavior on mortality. And when you do that, you sort of get to numbers like this. And again, it's a way of articulating the burden of disease and the burden of poor health attributable to different exposures, in this case alcohol, and we actually break it down by these different conditions. And this is something that's done nationally as well here in the city. So I show this really just to sort of illustrate the point about the need to demonstrate the importance and the prominence of these issues in a larger public health framework and from a prioritization perspective.
Can you just go back to the
Yeah.
previous one? Can you explain the difference between the contribution of alcohol liver disease and liver disease to
Right, so
alcohol-related deaths?
yeah, I mean, these are 100%, you could say these are sort of 100% alcohol attributable because they're defined that way.
Okay.
So you would say that in New York City there's, or this is the state actually, there's 600 alcohol liver disease deaths, and they're all attributable to alcohol. So you could,
Is there acute some?
well, because they're sort of specifically diagnosed that way. Whereas something like homicide, there's about 500 homicides a year in New York City. Not all of them are alcohol related. So the idea is to calculate a portion of the total that's attributable to, in this case, alcohol. And you do that by combining information about the prevalence of drinking, of heavy drinking, and the relative risk of that exposure on the outcome, in this case, homicide. You do that calculation, you calculate an attributable fraction, apply that total number, and you get some portion that you can then attribute to alcohol. We do that with smoking, for example, also.
Right, I was asking about the alcohol liver disease.
These are direct.
Other liver disease.
Right, so some portion of liver disease that are coded on death certificates is also attributable to alcohol. right? Not
It
all of
wasn't
them,
identified.
but wasn't identified.
Okay, that's what I was asking. Thank you.
So here, so a little bit now into using other data sources for understanding mental illness in our city. This is a project that came out of a panel report, set of recommendations from a city-state collaboration to think about the intersection of mental health and criminal justice that was convened in the wake of a number of media incidents, not unlike our recent experience, actually. And we took this opportunity to look at engagement and continuity of care in the public mental health system. So this is now using Medicaid data. So this is an example of sort of new data sources. And we identified a number of cohorts of individuals engaged in various parts of the public mental health system, many thousands of people, and looked at the Medicaid data to see what we could determine in terms of their engagement and outcomes. And these are the kinds of things we were looking at. Of this group of 20,000 or so people, numbers who had no prescriptions filled in the past 60 days, who had no evidence of outpatient treatment, who had multiple emergency department and hospitalization. So evidence of disengagement, evidence of poor outcomes. And not surprisingly, this was just, this is not the whole city, this was just in Brooklyn actually. And we see, many hundreds of people every month demonstrating these attributes of disengagement from service. So again, this is just purely on the data. And then we sort of took the next step and actually tried to follow up and investigate what was going on with these folks. And these bars, these are the different cohorts, but it's easier just to look at the overall numbers. We found that in some cases the data was telling us something and everything, in general was fine. But for, about half of these folks, there was a level of disengagement and a level of clinical concern about, being lost to follow-up, lost to care, potentially requiring intervention. And so it really just showed us things like this. Of that 50% group who had, that we were concerned about, most had no identified service provider. They had been touching the public mental health system, admitted to a hospital, gone to clinics, but had fallen out of care, and there was no sort of accountable provider or accountable point for follow-up and for ongoing treatment. So this is not surprising. These are some of the reasons why people fell out of care. I don't think it's surprising anyone in the public mental health system that this is a challenge, but it was sort of part of one of the first times we were able to sort of use this public data set, Medicaid, to actually describe and understand this phenomenon and point us towards where the follow-ups would need to be. So I think this is, again, it's the kind of area where doing more rigorous research and understanding about patterns of disengagement from care, reasons for disengagement, strategies for how to re-engage folks, what works and what doesn't. This is, this is what Dan and others have spent a lot of time thinking about, but this is an important need as well. And then generating feedback to the providers. Part of what our goal is to think about accountability and how from government perspective we can feed information back to the provider community to build accountability and quality. And so thinking about ways to take the data from the Medicaid file and put it back into the hands of providers for useful purposes. Okay, I'm going to go quickly through some other just themes of sort of some of the work we're doing and potential implications for research. Mental illness in primary and specialty care. So this is an ongoing ongoing challenge of how to better integrate attention to mental health and substance use into primary care. At the department, one of our main strategies, not just for mental health, but in general, for promoting best practice in primary care is promoting these electronic health records and health information exchange. We call this the Primary Care Information Project. And we've been trying in the Mental Hygiene Division to leverage some of those lessons and approaches for this challenge of behavioral health in primary care. How do we promote screening, treatment, and referral using EHRs? How do we promote and increase the use of high-quality EHRs in specialty settings? What are the parameters around information exchange, including issues of confidentiality and things like that? What is the role, how do we integrate behavioral health issues into emerging technology around personal health records? So this is a whole new sort of domain for behavioral health. Behavioral health has lagged behind primary care in the adoption of electronic health records, not least of all because of the financial incentives from the feds for adoption of EHRs, target physicians primarily, the Medicare and Medicaid incentives, and most public mental health practitioners are not physicians. And so there have been structural reasons why some of that incentive money hasn't flowed to the behavioral health community, but the state has stepped up with some funding, and there'll be increasing attention paid to bringing electronic systems into behavioral health. And I think it's going to be a big challenge to understand how they're being integrated, what the unique attributes are of behavioral health practice, and then how are they really affecting quality. I mean, that's a larger question, not only for behavioral health, but has special meaning in this sector as well. A word about housing. So, in some ways, in many ways, the mental health system acknowledges and explicitly incorporates attention to social factors in sort of total, approach to consumers. In our city, we have the largest implementation of supportive housing in the country. We have many tens of thousands of units. And we have this history of innovation with new populations that we're offering supportive housing to. Many people are familiar with these various initiatives, the New York initiatives. There's a lot of interest and continued expansion of supportive housing in the state and the city. A number of new initiatives coming out of, for example, litigation around, in this case, adult homes. And people might be familiar with this case where the model it's a state licensed model of assisted living for individuals unable to live independently. These are the so-called adult homes. They were made prominent. You've seen them in the news lately with some of the Hurricane Sandy issues. But there was a case brought around the fact that the way these places were organized, these tend to be large settings, many dozens of people, were not maximally community integrated. That would be required under the Olmsted Initiative. And many of the people who live in adult homes have psychiatric disabilities. And so there's a new push to provide supportive housing and community opportunities to people living there. And that's just one example. There'll be many more over the years. So continued progress of deinstitutionalization and moving towards more community supports. So there's that trend happening, and then another trend around potentially leveraging Medicaid dollars to fund supportive housing and to support the care coordination activities that go along with the housing supports that form the basis of the supportive housing model. So a lot of changes, sort of continuing expansion, and also the bringing in of a medical perspective and a care coordination perspective to housing that have big implications for this sector, and a lot of potential opportunities for evaluation of these new models. In particular, this issue that when you sort of bring in a clinical and a medical perspective to what is fundamentally a housing initiative, do you lose something that you might have had when it was more of a social service model? And then another big challenge, Medicaid reform. This is another, again, and when thinking about research and evaluation opportunities, big changes happening in the state's Medicaid system, driven, by a combination of interest in reducing costs and improving quality. For individuals with serious mental illnesses and substance disorders, we have a very fragmented system right now. That data that I showed you before from the Medicaid file shows how fragmented and disconnected the system really is. Partly because of our reimbursement structure, where people with serious mental illness who are on SSI, and many services in mental health and substance use are carved out of managed care. They're not subject to any sort of oversight or organization by a managed care organization or by government. They're paid fee for service with all the problems of incentives that go along with that. Poor accountability, poor cost controls, not good integration with other medical services. So that's a problem. For individuals with mild to moderate conditions, there's not a lot of performance measurement in our managed care system around behavioral health. The quality metrics don't include a lot of that information about that. There's a limited ability to promote best practice in managed care. This is just an example of the QUAR measures. These are the measures that the state evaluates managed care organizations on, quality of care. This is the list of QUAR measures for diabetes. Pretty good. Ranging from testing and other things to control of diabetes, et cetera, et cetera, et cetera. And these are the ones for depression. Something about antidepressant medication. That's it. Nothing about screening, nothing about outcomes. So we need to make sort of much more robust accountability in our healthcare system for behavioral health issues. How much on substance use either, by the way. So what's going to happen for individuals with serious conditions? Two things. The rollout of the so-called health homes, these models, new models of care coordination, not specifically targeting the behavioral health populations, but any all high-need populations, but interestingly, are sweeping up and incorporating what had previously been case management services funded by Medicaid for people with mental illness and people with HIV. Now sort of all coming into this new model of health homes. These are being sort of promoted by the feds and implemented here in the state in a quite widespread way. A lot of questions about their implementation. How effective will they be at coordinating care and improving outcomes for people with behavioral health conditions, given that they are a fairly generic structure with not a lot of requirements for specialization. And then on the managed care front, the city has been very active in promoting the development of so-called special needs plans. So if we're going to bring mental health and substance use services under managed care, we don't want to do so in a way that simply integrates all that payment and accountability into mainstream managed care plans. We want to preserve some level of specialization at the payer and care management level. And we think that by creating so-called special needs plans that integrate physical and behavioral health while continuing a specialization on these high-need populations, that is the right balance for the city. And we want these new special needs plans to promote best practices and new care models that are currently not really supported out there in the community. We have a lot of niche programs, we have a lot of special contracts, but things like new techniques for crisis conversion from ERs and hospitals, peer services, employment services. In order to get those to scale, we need to think about them in a managed care context. And we think that these special needs plans are ways to do that. And then as I said before, for individuals with more mild to moderate conditions, how do we expand plan accountability? How do we promote best practices in primary care through managed care strategies? So this whole environment is changing, and over the next several years, these new models of managed care will be rolling out. Many thousands of people will be moving into new forms of care management, and open questions about how well it's going, how successful these new models are going to be, how access will be affected, how quality will be affected, and ultimately how outcomes will change. So this is a whole other realm of potential research and evaluation as well. Condensing huge amounts of reform and change into a few remarks here, but this is pretty radical. It's going on.
Yeah, I mean, there's similar things going on in the HIV world, and in the realm of care coordination too. So there's like all of these like tailored, complicated HIV care coordination programs that exist, and many of these patients are going to now be eligible for health homes under Medicaid. It's a completely different, non-tailored approach to care coordination, and thousands of them will be transitioning. And I think we have some similar research questions in the HIV around how this is going to work for patients.
Absolutely. We had 10,000 slots of so-called targeted case management for people with serious mental illnesses in New York City that just got turned into health homes. And we do training through CUNY for the people that work in these programs, right? And it's some real open questions about how this new model, how we're going to continue to have a focus and an influence on care and care coordination for our populations in this larger context. Do you want to say anything about that, Dan?
Well, no, I mirror, those questions and concerns. I mean, and I guess some of the providers I've spoken with seem to believe that, that there's still going to be a need somehow to have some kind of targeted, more specialized models of care for particularly high-risk groups within the broader group. Now, how that will be, something like that would be supported and what that would look like and how people would be identified for that level versus, I mean, who knows? But yeah, no.
Adam, before you move on, is there any design to evaluate this, or is this, just one of these large policy shifts that is, a healthcare system shift that makes it very difficult to know how, if we will look back to say, was this effective?
I think
to add on to that too, like your earlier comments about no surveillance system for this. In the HIV world, we will evaluate it because we can see what happens to people regardless of where they go and get care. But in this situation,
I think it's a little bit of both. I think there is some attention being paid to evaluation, especially for the things that are sort of more rolling out, like health homes. Around the managed care front, I would say not as much, and not as much thinking and planning, nor ability, as Dennis pointed, to actually figure out what the right way to evaluate it is. It's a huge opportunity, and I would say. Okay, I'm going to digress just for 2 minutes on opioids, just because it's something we're spending a lot of time on. It's not mental health, but it's substance use, close enough. I think people are probably familiar with the topic in general, the emerging epidemic of prescription opioid use, misuse, and health consequences. This is mortality from prescription opioids, prescription painkillers, oxycodone, hydrocodone, etc. Just in the last decade or so, just an incredible increase in deaths here in the solid line that parallel the increase in use and sales of these drugs. And this is a sad story, right, of the sort of co-optation of, of sort of well-intentioned clinical practice around palliative care and pain management by pharmaceutical companies and others to really push the use of these drugs in a non-judicious way. And now we're seeing the effects, unfortunately. Here in the city, we haven't been affected as some other parts of the country have been by this epidemic. But we've seen, this is just to give you an idea of the scale of how many prescriptions in our city are being dispensed for the two large categories here. And oxycodone is the main one. This is emergency department visits that again parallel this. And this is mortality. Overdose mortality in our city has been going down over the past several years from heroin and cocaine. But opioids and benzodiazepines, other prescription drug that often works in concert to produce fatal outcomes, have been going up in the wrong direction. And so we're concerned that though we're not at the same level, we still only have 150 or so deaths, but we're worried that it's going in the wrong direction. And we also know a little bit about just to say, like, it's so much easier for me to present surveillance data about drugs than it is about mental illness, right? Just to digress. This is the geographic distribution of prescriptions. You see Staten Island is, where most of the prescriptions, or many of the prescriptions are being given, and the concomitant rate of mortality. And this is not your typical substance use map, right? This is not your typical substance use map. So we're seeing changing epidemiology. And of course, very important questions as we think about prevention and trying to turn down the supply of prescription opioids, because most of these drugs start with a prescription by a physician. So the actual interventions and strategies are not so hard to contemplate. As we turn down the supply, are we going to see switching from prescription pills to heroin? So these are some of the questions we're asking. So what are the strategies? Information and clinical guidelines for prescribers using the techniques that we have at the health department, like specific protocols that we can outline in our city health information recommendations. These are some of the things we put into there. It's about more judicious use of prescription painkillers, shorter durations. Not when you go and for a dental procedure or a minor outpatient procedure instead of 28 days of some drug the way most of us get. Maybe you only need 3 days. In the vast majority of cases, you might need only 3 days or less than that. Things like that. And then, I talk about surveillance. Every controlled substance prescription in the state is registered in a database that's administered by the state health department. So we can imagine, there's been limited use of that database to prevent non-judicious use, and we need to improve that database accessibility, lookup functions, etc. And we also will be hopefully getting access to some of that data in the future. That was a legislative change in Albany this past summer. It was a large bill that was passed to do some of these things, and part of that bill actually gave local health departments access to the controlled substance registry for the first time. It's very exciting. You can imagine a variety of other strategies that we can be using to control the supply of prescription opioids, more guidelines, using that prescribing data, as I said, for quality improvement, marketing, insurance strategies, how do we incorporate controls into EHRs. Okay, so in the last 5-10 minutes, very quick, I thought I would just say a few things about getting back to the concept of public health approaches to mental illness. What are some of the things, we don't traditionally do much of this in the health department, sort of take a community approach, prevention approach to things like depression, but there's a lot more, we think about screening, brief interventions, and clinical strategies in primary care and specialty care. What are some of the things we might be thinking about doing around upstream determinants of mental illness? And there's a lot of, emerging epidemiologic evidence that in fact these contextual factors have important influences. There are models, service learning for adolescents, experience score. This is a model for older adults about engagement, social connectedness as a depression intervention. How do we think about the work of the city in terms of neighborhood development, economic development, the built environment? These are questions. We don't have great strategies right now. I mentioned early psychosis. To me, this is the prevention approach to serious mental illness. Intervening early in the course of schizophrenia. This is a complicated slide, but the point of it, basically, these are the sort of different stages of life, early periods of childhood, puberty, and adolescence, where the first evidence of psychotic illness might manifest itself in early adulthood, the sort of initial manifestation and decline, and then later on. Now, importantly, this is not a progressive decline, right? There are opportunities to arrest the trajectory of schizophrenia and potentially reverse it. There's exciting new research on that topic. It's not a new field. This has been a field that's been rich for decades, but I think we have more evidence now about what it takes to create a program of early detection to reduce the duration of untreated psychosis, to develop these specialized treatment programs, and these are the components of what good clinical care is that can potentially, again, interrupt and maybe reverse the downward trajectory of schizophrenia. And we have no such programs in the city. Maybe a few boutique clinical treatment programs around that don't treat very many people. But we don't have a systematic approach to identifying, referring, and having enough capacity to do this sort of thing for everyone who needs it. For the many thousands of people, young people every year in our city who develop psychosis. So I think this is something that in the managed care conversation we need to be thinking about, how to build these systems through managed care, and also how to evaluate them and how to think about identification and dissemination. So I think this is prevention. And then lastly, a few words about early childhood. This is, again, the other prevention approach to mental illness, I think, is intervening in early childhood and addressing promoting healthy parenting and reducing exposure and effects of trauma. This is the ACE model, the Adverse Childhood Experiences model of the relationship between adverse childhood experiences and all other things, not just mental health, by the way. So folks are probably familiar with the ACE study. This was a big study in California many years ago that followed people longitudinally for a decade or so, adults, and then asked them about their early childhood experiences and then related it to their adult manifestations of health and disease, and showed this incredible sort of monotonic relationship between the number of these so-called adverse childhood experiences and things like smoking and obesity and depression and all these things. And this is the number of so-called adverse childhood experiences that people reported. And it's just very dramatic. This is depression, in particular in women. And these are the prevalence rates of depression as a function of how many of these adverse experiences they had. Really dramatic. And these are the types, these are the different things that we're asked about. And they all have this, these are odds ratios. They all have this positive relationship. These are just, the CDC actually incorporated the ACE measures into the BRFSS for 5 states back in 2009. And these are the prevalence rates. So this is now more population level, not that Kaiser ACE study. So here's, these are the prevalence rates of adverse childhood experiences in the adult population at a population level, right? 26%, 15%, 12%, right? This is incredible how prevalent these are. And these are the numbers, right? So 40% reported 0, so 60% reported at least 1. And there's so highly prevalent and highly associated. So back to the population attributable fraction conversation, we have a highly prevalent exposure with a pretty decent association with outcomes. So using the National Comorbidity Study data, this was a paper from 2010, they estimated the population attributable fraction for different mental illnesses, mood disorders, anxiety disorders, substance use, etc., of these adverse childhood experiences. And they came up with, let's look at overall, population attributable fractions of 20 to 30%. We can say that, this is sort of an exercise, it's not a perfect science, but if we say that 20 to 30% of adult mental illness is attributable to adverse experiences in childhood, that's a great opportunity for prevention.
Can you clarify why early childhood is missing here? Is it difficult to measure, or is it 0 to 3?
You mean in this particular study?
Yeah.
I think they just didn't ask it in the study.
Recall
Right.
that.
Right.
Just
So
again,
is there some thought of adding those kinds of ACE questions to the HANDS or to any other city surveillance?
we've thought about it for CHS actually. It's a
Yeah.
lot of questions. That's the challenge. But yeah, they did it at BRFSS, so we could think about it as well. Just to say, this is surveillance for early child development in Canada. There's ways of looking at, for example, kindergarten students and assessing their level of development. And this is this data that the health department in Vancouver presents at a neighborhood level of these different measures of vulnerability, developmental vulnerability, percent of children vulnerable on one or more scales. This is so-called early development index. So this is, this is surveillance for early child development at the population level. Something that we might think about doing here in the city, but we don't.
I mean, another question is whether or not that those ACE measures could be incorporated into the YRVSS.
That's another place
where you could act. It's actually not too late to intervene.
Right.
It's
the high school student survey.
Not at the individual, but using the data from the students.
Yeah, right.
The target research.
Okay, so I'm going to stop there. This is sociology from the 19th century, reminding us that the contextual factors and group factors, in addition to individual factors, are at the root of not only physical health but mental health as well. So, all right, I'll stop. Those are a quick run through some of this stuff, but I was trying to, offer some thoughts about population mental health and public health approaches, some of the stuff we're doing around people with serious mental illness, system change, but happy to have a conversation with them.
So, I wanted to raise a focus on the interrelationship between physical and mental health and mental well-being. Because I think even the surveillance data ends up underestimating the influence of mental health on adverse health outcomes. Because medical examiners aren't going to record the mental illness unless it's obviously related to the cause of death, immediately related to the cause of death. And increasingly, we're learning how the mild and moderate population, which has not yet gotten a lot of attention, of those who are impacted by mental health challenges and DSM diagnoses, but not serious mental illness, how their health is significantly impacted. We know that the seriously mentally ill have been reported to have a 20 to 25 year shorter lifespan.
Right.
Some of that may be related to the medications they're on, some of it is due to some unhealthy lifestyles. But the healthier individual with a mild to moderate mental health condition shows up in the community health survey in New York to have, by those, as indicated by high Kessler-6 scores, large stress responses, not specific psychological stress. Well, that's very closely associated with a lot of unhealthy lifestyle choices, tobacco and alcohol and lots of things. So undoubtedly, and while it doesn't explain causality, there's a very strong association between health and mental health. Positive health and mental health, as well as very poor health. And I would think that 21st century public health focus on chronic disease, now that we're very much sort of less focused on communicable, at least in economically advanced countries, that we are in chronic disease now, really to make a significant impact on managing chronic disease, it's really going to happen to begin to sort of take into account the influences of underlying stressors and mental health impacts that are affecting people's ability to manage these conditions in a more positive way.
I mean, you're absolutely right, and the community health survey data not only shows associations with behaviors, but also with, and the literature shows this as well, with sort of disease management, ability to adhere to medications and things like that. And so it continues, sort of emphasizes the importance of this sort of integration at the practice level. I mean, community level is one thing, but at least in clinical practice. And I think that some of these new strategies, like use of electronic health records and things like that, but more challenging is how do we incorporate best practices into primary care, like the collaborative care model. The collaborative care model in which specialty care and primary care are working together to manage mental illness is an evidence-based practice, hard to implement at scale. We've had around the city various clinics and hospitals that do it, but our challenge, I think, is how to disseminate it more widely. And it's issues of payment, reimbursement, and that's why we're investing so much of our time on the managed care front, because we think that those types of incentives and promoting best practices that come through managed care will sort of move the field forward. But it's not enough.
Well, following on some of that, so you talked about part of your research agenda being about, pulling together some of the existing administrative data sets that you have, such as Medicaid claims, which includes not necessarily diagnoses, but people who are, maybe it does,
Yeah, it does.
but treatment information. And linking that, starting to link that with vital records, for example, can begin to do some of the things that Neal was alluding to here, describing the co-occurrence of serious mental illness with certain chronic conditions.
Yeah, I mean that's how some of those studies that demonstrated that mortality disparity were done, by taking registries of individuals in psychiatric hospitals, for example, and matching them to vital records data. An analogy here in the city could be using Medicaid data to do the same thing.
Right, and could you also do the opposite with birth records, matching to Medicaid, birth records from 20, 30 years ago, matching to Medicaid claims data today? I mean, there's imperfections about it. But
Right. I mean, that's the thing we talked about this. Like, we don't have longitudinal data on very much of anything. In the world of HIV, there actually is longitudinal data on people living with HIV and needs and outcomes and things like that. We don't have the same thing for people with mental illness. And can we either do it directly by setting up cohorts, or potentially using administrative data to do it in that way?
There are two things that I would just like to ask you about. A couple of slides ago where you told me about the childhood, the Vancouver slide,
Yeah.
and there was quite a difference in the color. And do you know those communities? Why were some communities so much darker in terms of the level of childhood?
Which is the sort of impairment in child development. I mean, it's the risk factors that we know.
That we know about. So we can take that and we can use it here.
That's the idea.
And the other thing I was thinking about is that very often we don't know how much prevalence there is in terms of depression until we have an event like the World Trade Center or Sandy or something. And then people often come forward with mental health issues, which we never would have seen before if it hadn't been for a particular circumstance. How does one build on that and also make it into a public health campaign where it's okay to ask for help? But I think there's still a stigma around people thinking that it's my fault that I'm feeling so down or whatever.
I mean, one approach, I mean, there's community approaches and population approaches around stigma. Those are often short-lived and not particularly effective. Screening is certainly one strategy, right? When you sort of universally screen and you ask primary care physicians, not in the specialty sector, but in the primary care sector where people are coming for routine care, and you try to universalize screening as one way of at least addressing that.
Which could be either the health home. Is that the same as medical homes that we're talking about?
Well, the medical home is the term for the clinical service environment. Health home is the term for the care coordination activities that revolve around it. So it's a component of the medical home. It's specifically around the navigation and the coordinating and the connecting and the information exchange, as opposed to the clinical practice itself.
So if doctors were asking not only how are you, what's your diet like and are you exercising, but also some specific questions about.
Exactly. Now, I don't think we have great community strategies, frankly, for reducing stigma, for promoting engagement. I would say that's another sort of one of our gaps, frankly. Go ahead.
Oh, and if you look at the relationships between low health literacy and mortality, we have 30 years of great data that say they're highly associated, and yet Australia is the only country that's done a national assessment of the citizenry mental health literacy. We have no really ongoing studies here in the United States about the relationship between health literacy and mental health, nor do we have any promotional campaigns to even elevate the general populace's understanding of mental health issues. And I have no hope for the health exchanges that are going to be set up to move all these millions of people into managed care, because as we've been assessing them across the country, we're still in very rudimentary stages. They're going to be very underpaid people, sort of helping you navigate the choices of your plans and the use of your plans. And I haven't seen mental health benefits even on the radar screen.
So, your Medicaid data were interesting and pretty compelling. First, just a comment that in the one slide that you showed of those with high clinical need, it seemed to look as if only 5% were refusing services. So it really was this picture of fragmented, horribly fragmented care. Isn't that, I don't know how difficult it is to surveil that data source on a routine basis, but isn't that one, at least, surveillance source for monitoring and evaluating the shift to managed care? Because your main outcomes of interest there are less fragmented care, right? And
Absolutely, I think you're right.
And so to what extent are the populations appropriately aligned, the Medicaid and some of the big shifts in packaged care?
They're pretty well aligned. I mean, in our city, having a serious mental illness is pretty highly correlated with being poor and being, and with a very debilitating mental illness with being on SSI, which is an automatic Medicaid eligibility. So the vast majority of people, not all, the majority of people with the most serious and debilitating mental illnesses are on Medicaid. And so that is a good way of monitoring the this sort of state of the population with serious mental illness.
Are there any potential comparison groups here as these shifts in care and structure of care roll out?
With sort of a better managed or more accountable model of care.
A natural experiment.
Well, you could. I mean, I don't really know. I mean, it's hard to, now that I'm in academia, it's a little hard to monitor the development of the health homes regionally, but there is actually, I mean, it isn't like it's all being turned on at once. So I suppose it might be possible to come up with some kind of a way to try to see whether development of any version of these health home arrangements for that population could influence some of those factors that you're monitoring.
I think what you're saying is it's less about finding a comparison population.
I think it's
than finding differential information.
Oh yeah, I'm sorry.
Exactly.
Of best
Yeah,
practices.
that's what I meant.
Absolutely.
Yeah.
There's a vast network of providers, community-based providers, hospital-based providers, individual practitioners, interacting in all kinds of different ways.
States will do it differently.
Well, even in this state, they're doing it differently in different boroughs. They're doing. It's not like it's all going to be the
So
same.
there's timing.
parts of the
There's
state.
there are, you're right, other states. There's within our state, for example, the special needs plan model, the integrated physical and behavioral health managed care model that we're going to do in the city will probably not be the same model that's done outside the city.
Right.
So there's opportunities to compare there. So yeah, there's a lot of variability.
Is it hard to track the data when there's so many different kinds of mental health providers and social workers, political psychologists?
Right. So it gets very complex to tease apart what the relative contribution is of these different things are, but that's where you guys can tell us how to do it.
I know you've been looking at community resilience in terms of trauma effects and disasters, but looking at your map, was there any interest, do you think there's any interest in looking at community resilience and community resilience building as a preventive strategy?
Right, so I mean, we think about that a lot, and I think it gets to these questions of what are the contextual determinants of mental health,
Yeah.
and this, you know, and what the specific strategies for building community resilience would be, and how do they differ from the kind of approaches we might want to take more generally to enhance communities' sort of ability to manage and prevent.
I would think that they correlate pretty closely to the community resilience strategies that are employed for trauma and disaster, so that it might have some, so that as long as one was looking at those kinds of strategies, this might be one that's
And, you know, we're going to be rolling out in the near future a pretty large response to the hurricane that will involve a lot of on-the-ground crisis counselors. There'll be a media campaign. It's based on the Project Liberty model that we did after 9/11. And so a big part of that campaign is going to involve interacting with community leaders, community groups, faith-based organizations, etc., to bring these messages of coping and of sort of managing through a crisis.
Right, but one of the issues with that is that when you do that depending on how you fund that, you can't really do a proper study because you're supposed to be providing service.
Oh yeah, right, we can't do that.
And what I'm asking about is the possibility of thinking about finding ways to start studying community resilience more systematically to see if it works and it's effective.
One thing we've always been thinking around these issues of trauma and resilience is that we don't have to wait for things like Sandy to do some of those studies. Like the ACE data tell us, there's a baseline level of exposure going on in our communities that's very high.
I think you also mentioned the importance of building parenting skills and parent capacity. So, and then just wondered if you could say something about how one scales things up. So like if we know, for example, nurse-family partnership and that kind of early support for young parents is really effective, but it's often, reaching small groups of people. And
that's a challenge. When you're stressed, that's why I sort of flew by that slide. But what are those are when you rely on individual level strategies like one-on-one parent support, like nurse-family partnership, you're in a world of resources and scalability. That program is an effective program. It costs maybe $6,000 per family per year. It's quite expensive. Some of these early childhood programs, these evidence-based early child development programs, Abecedarian, area preschool, these things are in the realm of $10,000 to $11,000 per family per year.
But is that where the politics comes into it? Because they ultimately save money. So it's just.
So this is the
how do you convince people?
They're not under a politician's watch.
Well, this is one of the things I wanted to go back to the HIV lessons that could be potentially thwarted here, and there's been a lot of effort looking, at cost effectiveness of different interventions. So not just not comparing the cost of money that you spend to what you save, but actually linking it to outcomes and societal benefits related to subsequent morbidity, public dollars used, etc. So it takes a while. First, you have to find out what's effective. It sounds like you may have to do things like that where you can begin to examine, and then you can decide how best to target things. But the one thing that I would really be interested in knowing more about, and if you could do something like this, is the one thing that has mobilized the field of HIV in the last 5 years in this country has been this national HIV/AIDS strategy that Obama has put together. And around that came actually from sub-Saharan Africa, this idea of putting together, the so-called HIV cascade. And we've talked about this a little bit, where it's basically a bar graph that starts at the top with everyone living with HIV. In the U.S., we have a bar of 1.1 million people, and then of those, and for you, it could be severe mental illness. The next bar is what proportion of them are diagnosed. The next bar is what proportion of them have received care in the last year. And the next bar is like what proportion of them are continuously retaining that care to be, and then another one on medications, and then another one successfully treated, because not everyone on medication is successfully treated. Putting that cascade together has mobilized the field of HIV research, practice, into this notion of how do we best go about implementing, using the evidence-based strategies we have, and how do we focus our research dollars on finding out which strategies will impact which aspect of the cascade. I think there are so many parallels, and I know you said this too, between the HIV world and the mental health world, and there's a place for a cascade in mental health. And I think it's in the Department of Mental Hygiene, where you're taking a public health focus and long view on this.
I think we have the component parts of that in large measure, but you're right, sort of putting it together in that way would be very useful.
And that's where you start, and you can break it out. You can look at Brooklyn's cascade, you can look at cascade for males and females, but the main thing is to start with the citywide cascade. Decide who's in, what is it? Is it severe mental illness? Is it, depression? I mean, you decide what the denominator is, but then you construct it citywide and go from there.
So where does the promotion come in? Where does the cascade keep going and end up?
In the HIV world, we stop it with viral suppression, which is what most benefits the individual and also what most benefits society and prevents spread. And you don't have the spread issue, but you do have things that people with severe mental illness do that affect society.
But that is one big difference, right? I mean,
Yeah.
this is a disease management model.
Right,
They
as
were-
opposed to promotion,
suggestion, which is
mental
has value, which has strong value in and of itself.
It's not just disease, it's prevention.
It's prevention.
Because, I mean, they're one and the same in the HIV.
Yeah,
I
it's-
think
no, but I'm talking about.
But it starts with diagnosis, I think, is the
Yeah,
point. as
yeah,
opposed to-
early diagnosis.
But there's,
But it
that's,
could go,
Well, I
it
think-
could keep going.
I think the analog to the viral suppression for mental health, mental illness would be functionality. So that, because depression and anxiety, the analysis of the NCSR demonstrated that 60% of folks who have significant anxiety and depression have lots of impairments, very significant functional impairments. So we're not talking about a condition that is very trivial, despite the very large numbers of the population that in one course of the year, 25 to 30% have a DSM diagnosis. And there are significant functional impairments, either personally, in the workplace, et cetera, et cetera. So the cascade could lead to, you could have depression, but still be able to have like higher level of functioning or lower level.
and the fact is that we have almost no way of tracking that, the ultimate outcome that we're interested in, either functional status, you can imagine scale scores, like the PHQ-9 score can be used as a measure of treatment efficacy, anything like that. We have no such measures in all those data sources that I talked about. There's no analog of sort of viral load. There's an analog conceptually, but our ability to track it and monitor. Now, this is a question for us as we think about, new managed care design. How do you hold a managed care company accountable for recovery, for functional status? But we can imagine a situation, a system in which that's an obligation of providers to assess functional status on an annual basis, for example, and track it. But it's an amazing system that doesn't have any of those outcomes as a matter of routine monitoring.
If you were to generate a cascade, you'd be doing it largely from a combination of administrative data and survey data,
Right.
rather than registries.
Exactly. Rather than
Administrative referring to
Medicaid.
colleagues.
Right, we have the same issue. I mean, we don't know how many people are really living with HIV. We have
Right.
to estimate it from different methods. And the administrative data tell us how many people are in care.
But for serious mental illness, the Medicaid data, as we said before, is pretty good. It's just, it's good in terms of capturing the population. How good it is to measure the kind of things we're talking about, it's very complex.
How do you link that to your promotion and prevention efforts for people who, before they...
Well, getting undiagnosed HIV is a big part of finding people who have HIV who are undiagnosed is a big part of it.
But in terms of preventing HIV transmission, how do you think the cascade to that?
Well, that bottom line of lowering people's viral load in care is the way.
Is it self-prevention?
Self-preventive strategy.
Less likely to transmit.
Because they're less
Yeah, okay.
I mean, we're very much in the realm where treatment and prevention are sort of one
Okay.
in the world of HIV. It's different for you guys. This is dealing with, who's sick, who has mental illness today, and who's going to be requiring it.
Although there's some analogs, like for example, the treatment of maternal depression is prevention
Right, that's-
for and promotion of healthier childhood. Right?
Yeah, that's an important one.
There are connections between treatment. There's sort of analogs.
But I mean, I
And
think
also across systems, because I learned that children by the third grade who are absent from school by 30 or more days missing school in the course of a year, they're they're highly likely to be high school dropouts. So these are 8-year-olds who are not just who are not hanging out on streetcars with their peer group, right? So there's something to be investigated very early on that shows up in our public schools that is likely to be highly associated with poor mental health outcomes and ability to hold down jobs, to get a high school diploma, possibly go into college, et cetera, et cetera.
So that kind of cross-system surveillance is that's something Lauren is also really pioneering in the health department. Matching, for example, some of our health department surveillance data with the Department of Home Services data. This, child welfare, homeless, correctional, sort of the list goes on of overlaps between, the public mental health system and these other services, education.
So, thank you, Adam.
Okay.
I think you've given us a lot to think about.
Okay.